dramatic music. I love it.
I quite like this one.
Yeah.
It's like two sticks.
Yeah.
Oh no.
Are we all going to be friends
Oh,
and stick
no.
together?
I think so.
Oh. Could you just help me now? I've got the policy up.
The other couple there.
Oh my God. That was so close.
If I shut that bit down.
Yeah, you
Do you want
can
me
do
to hold my ball?
Oh, back there.
Because it might.
this on that
I'll
one.
hold my ball. You might hit me.
We're awake. Sorry.
Remember,
This doesn't
Yeah,
take long.
mine's pretty much next to hers. Yeah.
just sit back.
Right.
Felt like yours was a bit
Good
closer.
afternoon, everybody.
What,
We're
like
about to
No.
start.
There.
So if anyone has any
Okay, fine. It doesn't make a
problems
difference.
hearing,
Every little else.
perhaps you could let me know. I can hear people talking, so it would be nice if people could give us a bit of quiet
Just putting me off.
as we're starting. Can I mute them? Thank you. So this is, I'm
Oh,
Dr. Willis.
it's your fault saying there's a what?
There's a leaf in there. Yeah.
Excuses.
Seagulls. Well.
Oh, close. Close one.
Don't hit mine.
I was going to do some weird bowling.
I work in the orthopedic department,
Nice
Oh,
job. So that's
and
number
I'm
3,
an
right?
elderly care physician.
Yeah. Good.
Okay. I think you can do it as well. Yeah. Hit it nice and softly. Oh! No. No. That's, yeah, it's going to be 4 now.
It's your fault. I'm going to blame it on that.
4 now. Unlucky.
Okay.
Oh, you think they're not even watching? No.
Sometimes
There's
like,
going to
you're
be a
winning.
hole and everything's going to
Yeah,
change.
that's what happens.
Right now it's even.
Can I mute them?
There's like where's the hole? Oh,
That would mute me, wouldn't it? That's no good.
ruin everything.
That's
Oh, that's a really good one.
it's hard.
No, but the thing is, like, you want it to be on the raised bit.
Yeah. Yeah.
See that raised bit?
It
It's
can
not
roll
easy.
down.
It's not easy. This is where people start blocking. Well, everyone really. That's quite
Okay.
a similar sort of ball, really.
Yeah.
As you can see which ones have muted their phones.
I would recommend going like up this way.
I think we'll just have to carry on.
Yeah, okay.
Hit that rock and then go that way.
Is that okay with you?
Is that all right?
Bit of background
Yeah, we'll just carry on.
Oh, my background is all
So essentially, I don't know whether you're aware, you might already be aware, you can tell me if there's anything that I'm already repeating for you, but there's a best practice tariff that exists for hip fracture patients, and there are similar tariffs in other specialties already. The best practice tariff came in for hip fracture in 2010, and it's a specific set of criteria that was set up for patients over the age of 60, which transformed the care for hip fracture patients because they were quite a neglected group, and the criteria tend to change over time. These are the current criteria whereby they have to have prompt surgery, they have to see a geriatrician within 72 hours, they have to have a falls and bone protection assessment, they have to have an abbreviated mental test score before surgery so that we can detect whether they get delirious. They have to have a nutrition assessment, they then have to have a second delirium assessment after the operation, and they have to be assessed by a physio following surgery. You can see from this slide, they collect all the data for hip fracture on the National Hip Fracture Database, and you can see from this slide at what point it was that orthogeriatric care was firmly established at the Conquest Hospital from this black line, which is when the orthogeriatric assessment, prior to, I think it was about December 2013, some patients saw an orthogeriatrician pre-op. Once all patients managed to see, or the majority of patients got to see the orthogeriatrician within the 72-hour period. The blue line is how much payment the trust was getting. The payment isn't really what's important. It was just the driver that was put in to improve the standard of care for the patient. And you'll see from the next slide that actually that was what was successful, because the other things that are important is the time to surgery, which is the red line. So although the time to surgery before that point did actually go down, which it's really, really important to get the patients to theatre quickly because the complications go up. As you can see, the black line is the 30-day mortality, and that didn't actually manage to go down until December 2013. So I think the biggest impact that was probably had was the fact that the orthogeriatricians were seeing the patients. So with that, you wonder, well, what is it that we do? This lecture was meant to be about orthogeriatric emergencies. I tend to hope on our ward we try not to see too many orthogeriatric emergencies, because a lot of it I try to do is preventative medicine. So it's about optimising the patients before they actually have the surgery or when they come in right in the door, which is more what we do. You know, historically, when I was a junior doctor, we were called to orthopaedic wards when the patients were peri-arrest, and that's an orthogeriatric emergency. There's absolutely nothing you can do except say, yeah, that patient's going to die. So what we do is the perioperative medicine to try and prevent those situations, and when you do it really, really well, patients simply do not get as ill on our wards if you deliver good perioperative medicine. So that's what I'm going to educate you a little bit more about today, rather than talking about how to manage acute medical patients. So now you'll find that with whatever specialty you're currently working in, there are many more tariffs and many more guidelines coming in, because the majority of patients in hospital are frail elderly, whichever specialty you go into, unless you're going into paediatrics or maybe obstetrics. This is the bread and butter of your workload. So the anaesthetist brought in guidelines in 2014 about the care of perioperative elderly patients. They brought in some more in 2019 about caring for patients with dementia, and the general surgeons have now brought in some about frail elderly patients also. I think there's a tariff coming in for patients undergoing colorectal surgery, where they want geriatricians on the wards assessing those patients. I'm not sure quite how far we've got with that. So in summary, what I'm planning to talk to you today about is frailty, perioperative optimisation, what we do specifically with pain management, because I think if you don't get that standardised, that can become quite complicated in the elderly. 10% of our patients are admitted on anticoagulants. The anaesthetists are trying to standardise their care, but we also know what things we think are acceptable from their guidelines, and we can sort of help them. If you get a different set of anaesthetists for hip fracture patients, I think it can be quite frightening, because they're very, very sick patients. And then a few common post-operative complications for hip fracture patients, and a tiny just touching on multidisciplinary team management. So the sort of bread and butter of what we base our clinical decisions on is around frailty. And I suspect you're all familiar with the Rockwood frailty scale that I think is meant to start in A&E. It's totally dependent on how in-depth the history you take. So if you don't get an in-depth history from the family, you're not going to make the right assessment of frailty on the patient. Just today on our ward, I think half the ward of our 28 beds are hip fracture patients. And when I did a glance around those patients, of the 15 patients, 10 of them had a frailty score of 7. I think one of them had a frailty score of 5, and the others had a frailty score of 6. So they're all mild, moderately or severely frail, with the majority of them, 3/4 of them are severely frail. So you can see what we're dealing with these patients. You have to treat them very, very gently because they're all on the tip of the iceberg for getting sick. We occasionally get somebody with a frailty score of 3. I would imagine even within the hospital, if you're fit and well, you're not in hospital. We just don't see patients like that. And we know that the 1-year mortality for a hip fracture patient is between 20 and 30%. We're a very, very large unit. We have 630 hip fractures a year. The average age is 85. We have probably 2/3 of them are women, and the length of stay is now about 15 days, with our mortality at about 7.5% at 30 days, which is a bit above the national average. And we know that these patients end up, 80% of them end up with some level of dependency, with 20% of them dead at 1 year, and 30% of them with some level of permanent disability. Their leg, it just never recovers after a hip fracture. And we can tell from the frailty scores that at 3 years, a lot of them are not surviving based on their frailty scores, which that then impacts upon the decisions that you make about their medication and about their clinical care, and when you're speaking to their families about what their outcome is going to be. You hear people saying, well, they were fit and well and all they did was break their hip, and then they've had this massive deterioration. But none of these patients, when I tell you what the frailty scores on the ward are, none of these patients before they got to us I would class as fit and well, even if their families perceive them to be fit and well. They're not fit and well. So with our perioperative optimisation, what we aim to do in our department is to deliver standardised care. The more you can standardise the care for patients in a very simple way, I believe the better the care is. So we aim to give a fasciailiac compartment block to every patient when they're in A&E. If we can't give it in A&E, then we try and get our junior doctors to give it. The major problem we have with that is the patients on anticoagulants, because that's the major contraindication. There are a few other contraindications, such as heart block, or if the patient's very obese or the anatomy's difficult, or if they've had vascular surgery in the area. But I think our rates vary from sort of 60 to 80%. Some patients are not very compliant. Some patients aren't in a lot of pain with their hip fracture and don't feel that they want a block. We have to do the mental test score on every patient. The sooner we can get intravenous fluids in the patients, the better. When you break your hip, you'll have significant blood loss just with the injury. Also, a lot of patients are on antihypertensive medications and come in slightly dehydrated. I find that it's quite common for our juniors not to really always know what's in a bag of fluid. I don't know whether you're very aware of or how much sodium and potassium patients need. So our juniors really, really love Hartmann's. I can't say I'm the biggest fan of Hartmann's, because when you ask surgical juniors, well, what's in Hartmann's, how much sodium do you need? People don't really seem to have an understanding of what's in fluid. In a bag of Hartmann's, there's about 130 millimoles of normal saline, and it also contains a small amount of potassium, just 4 millimoles. So it's important that when you're prescribing fluid, you understand what the patient's urine electrolytes are and what is actually in the bag of fluid that you prescribe. There's more sodium in a bag of normal saline, but not potassium. So if the patient comes in hypokalemic with a potassium of 2.7, there's no point just giving them Hartmann's, because it simply isn't going to raise their potassium. It's really, really important when you're prescribing the fluid to think about what they're getting. And also, the sooner we get a bit of fluid in them, the better. And it's similarly post-operatively. We've had a few problems post-op when people just give Hartmann's or just then give normal saline. And we've had a few cases on the ward where patients' sodium post-operatively, they're given Hartmann's and normal saline, then patients don't eat and drink for a few days, and we get sodiums up to 170 occasionally, which again is not ideal. There is now, I notice on Microguide, there's on the doctor's handbook, there's some new education about hypernatremia, because that was quite limited before. When you go and look up how to treat hypernatremia, it's quite hard to access what you actually do for that. But on Microguide, there is now a section on how to treat hypernatremia, because in elderly patients who don't eat and drink, it becomes more of a common problem. I think it's in some ways maybe worsened by what fluids we give the patients. But when you think about how much sodium a patient needs, they generally need their weight in millimoles in a day, and then you look at what we're prescribing them. If all you're giving them is Hartmann's day after day, and you're giving them, say, 2 litres in a day, clearly you're giving them too much sodium. So it's worth revising sort of fluid balance in those patients. Then I'll talk a bit later about our standard pain management, which we give them. We risk assess them all for VTE because clearly they're all at risk of thromboembolism. Again, with our patients, renal impairment's really, really common. Lots of them are low weight. Again, on the Microguide app, I don't know if you're aware of the table that's on the app. Do you know where to find that on the Microguide app about the dosing for VTE? Have you ever seen it, ever accessed it? I've got references at the end of where to access it, because if you go on the Microguide, there's a helpful pharmacy, and on that it tells you what to give for what level of renal impairment and what to give for what weight of the patient, because there's quite a variation in how much Clexane you should be giving for patients depending on their creatinine clearance and their weights. You can remember it for the your standard patient, the 40 milligrams, but when their renal function varies, you give them less. When their weight's less than 50 kilograms, you give them less. And when their weight, I think it's greater than 100 kilograms, then I think you give them double dose VD. But remembering everything, it's quite difficult, and it's quite hard to find out where you access that information. The other thing that we do, which when you try and look for the evidence behind it, it's very, very hard to find. But just from my practice over, I don't know, the last 12, 13 years, we withhold the antihypertensive medication. So when the patients come in, we just cross it off for several days. If the patient has high blood pressure, you get called to give an antihypertensive. It's much, much more common that where these patients have blood loss and are a bit dehydrated, they get low blood pressure, they then go to theatre, they're given a spinal anaesthetic, their blood pressure goes even lower, they lose another 2 units of blood, it goes even lower, the physios go to get them out the following day, they're given their antihypertensives, they then faint and they have a MET call. And before you know it, they've got an acute kidney injury. So all of this you can prevent. So on our ward, we don't want any excitement. We don't like excitement. So if you follow these standard perioperative optimization guidelines, you can just prevent these orthogeriatric emergencies. The thing that we do is continue with beta blockers. If lots of our patients have atrial fibrillation, if you stop a beta blocker acutely, they'll go to theatre and then they'll go into fast atrial fibrillation with the anaesthetist, which they don't really thank you for. Also, if you stop a beta blocker acutely, then the patient can get a reflex tachycardia. Sometimes if they've got a low heart rate, we might halve the beta blocker, but I would never stop it acutely. And we just monitor their blood pressure. It's not uncommon in these very, very elderly, frail patients. They've been on antihypertensive medications for years and years, 20 years, and we just find we never restart them. We find that they've got autonomic neuropathies and their blood pressure control is clearly completely and utterly changed. And they often get hyponatremia also, which when they're on a diuretic, they often just don't need them anymore. The other thing we do is transfuse them all so that they've got a haemoglobin, to make sure that their haemoglobin is greater than 100, because we know that they're going to lose blood in theatre. And every patient, our juniors are really, really good at just asking them about resuscitation and going through a respect form with them, because it's not common, but it's quite unpleasant if you haven't discussed it and the patient dies perioperatively and you then have to ring the family and it's not been discussed. It's fine if the patient says they want to be resuscitated, even if we think that maybe isn't the most wise decision, but at least if it's been discussed, if the patient has got a resuscitation, a DNAR form at home, you find out that they have got that and you can fill one in. And also when you word it to patients in the right way, very often they do make what I would class as a sensible decision about it, and quite often they're quite happy to discuss it. Sometimes it can feel a little bit awkward when they're about to go to theatre and you've told them they're having a major operation, but sometimes I tell them if they want to just think about it, it might be something that it's important for them to think about again in the future, because when you look at the frailty scores and their outcomes, we know that's important for them. So our standard hip fracture pain management, we keep it very, very simple. We give them regular paracetamol. We've tended to put everybody on a buprenorphine patch so that they've got some background analgesia and they don't have to ask for it. However, I would say we take the patch off probably in 20 to 30% of patients. Because if they're very, very low weight or they have a tendency to delirium, even that patch can be too much for them. It's remarkable how many patients with IV paracetamol are fine, even with a hip fracture. The buprenorphine patch, it goes on and it can take up to 72 hours to get into the system. And then it stays on for a week. And then we only give them it for 1 week. And then we take it off. And I warn the patients, if they start to feel muzzy in the head, at all sick or delirious, we will just take the patch off them. But, you know, I think this week I've seen probably 4 patients who weigh about 42 kilograms, and I've just taken it off them straight away, because you can just see if they're 96 years old and they weigh 42 kilograms, they are going to get delirious with that patch. It's probably just not worth even waiting for them to get delirious before you remove it. It's too risky. And then we just give them PRN Oromorph. And our nurses are very, very good at giving it when they need it. And generally that combination works fairly well with a bit of antiemetic. We never give them codeine. We never give them tramadol, unless they say at home it's what they really, really like and they're always on it. You get the odd patient who comes in and they're already on some really high dose of opiate. And if they're on a high dose of opiate at home, then we're happy for them to stay on that. But that's very, very occasional. And we avoid all non-steroidals because the patients will just have a GI bleed on it. And pain management in the elderly, it can be very, very difficult to know when they come in whether they're delirious, whether they're in pain, or whether they're cognitively impaired. So we tend to use the Abbey Pain Scale. I don't know whether that's something that you're familiar with, which looks at the six areas of their sort of vocalization, their facial expression, their body language, to assess as to how much pain they're in. Is that something you've seen before? It's one that's used specifically in patients with dementia to see, and it gives you a scoring system, so that's something you could refer to on your wards if you've got patients who are in pain who've got dementia. Then we developed a new guideline with the haematology department specific to our patients for hip fracture who are taking warfarin. We used to give them 5 milligrams of vitamin K. We're now just giving them 10 milligrams. We found we gave them 5 milligrams, then we'd wait 6 hours if their INR was high, recheck their INR, and then have to give them another 5 milligrams. But that tended to delay them going to theatre because we'd have 2 lots of vitamin K and we'd have a 12-hour window. So now we know the maximum dose of vitamin K that you need to reverse their warfarin is 10 milligrams. The majority of our patients are in with atrial fibrillation. The only patients that are slightly special are the ones with the metallic heart valves, who you need to be a bit more cautious about reversing their anticoagulant. But apart from the metallic heart valve patients, essentially these patients need to get to theatre. There are guidelines for elective patients who are on warfarin and DOACs, and there are guidelines for total emergency patients who are bleeding in front of you. Our orthopaedic patients are slightly different because we want to get them to theatre within a sort of 36-hour window, which isn't a true emergency, but it's also not a true elective. So there are very few guidelines for this patient group. So we've sort of developed our own within this. And then if their INR isn't down, we can give them some Beriplex, some prothrombin complex to reverse their INR. But generally, we try and get it down with the vitamin K and then wait a bit, and it usually works. The anaesthetist won't want to anaesthetise them. They like to give a spinal anaesthetic because that's the safest thing, and they won't want to do that if the INR is greater than 1.5. If patients we believe are truly, truly high risk of VTE, so they've had a clot within the last, or a stroke maybe within the last 3 months, then it may be that some perioperative bridging with a treatment dose of Clexane would be thought about. But you've got time then to consult some sort of physician or haematologist about that sort of thing. And you always have to bear in mind what their bleeding risk is with those things as well. We always assess their stroke risk, or the orthogeriatricians do when we see them. I'm not sure our juniors do, and their bleeding risk, just when we're thinking about these things. And then the majority of the patients in this region, I don't know about where else you've worked, loads of patients are on DOACs rather than warfarin. And it's something that we talk to the patients about, whether they want to swap off their warfarin and onto DOACs, as the evidence is that they're safer drugs to take generally than warfarin. Some patients just love their warfarin and want to stay on it, especially now with the COVID and things, that rather than coming up for INR checks, I think generally here they do a pinprick test in the community. But if they're on a DOAC, then they just don't need any blood monitoring. And it's been shown to cause less hemorrhage once you're actually established on it than warfarin, probably due to all the variability on it. But it's important that when they come in that we stop the DOAC. You know which DOAC the patient is taking, because the excretion of the DOAC varies for each different drug. We know what their full blood count and their renal function is, and it's all clearly documented, especially the timing of the last dose. And then assess their bleeding risk as to what type of surgery. It sounds a bit crazy, but hip fracture surgery we define as low bleeding risk surgery. Whereas if you've got a periprosthetic fracture or revision surgery, it might be defined as high bleeding risk surgery. It's a bit more major than hip fracture surgery. And the surgeon and anaesthetic team need to be aware that the patient's on a DOAC. We know that if the patient's delayed a significant amount of time, which is why the best practice came in, then the mortality at 30 days, it starts to go up. Which is why even when they're on a DOAC, we want to get on and try and get their operation through. So we need to calculate their creatinine clearance, and then we have this guideline which we've developed with the haematology department. So dabigatran is 80% renally excreted, which is why if their creatinine clearance is very, very low, you have to wait for what we're classing as low bleeding risk surgery with an neck of femur. You have to wait up to 72 hours, well, I showed you on the previous slide, your mortality starts to go up after 48 hours. So those patients who come in on to Bigatran are quite at risk. And if they're going for what we call high bleeding risk surgery, like revision surgery, and they're waiting 96 hours for their surgery, their risk of mortality, it's really starting to go up. The other DOACs are not quite so bad when they're going for neck of femur surgery. If they've got bad renal function, they need to wait the 48 hours, which was part of why they developed the tariff that patients need to get operated on quickly by the surgeons, you know, when they're not on these drugs, because we know that their mortality goes up after 48 hours. However, if it's a high bleeding risk surgery, you're given no choice. The patients, if they've got bad renal function, you just have to wait, because the risks to them if they're going to bleed on the table are too great. And post-operatively, with those patients, we decide when we're going to restart them on their anticoagulants, depending a bit on what the wound looks like and depending a bit on the frailty of the patients. Sometimes people say, well, who do and don't you start on them? It depends a bit on what the patients think, what their families think. If someone's admitted on a DOAC, but actually they've also come with a peace plan, and they're from a nursing home, and they've got a frailty score of 7, and they're going back to a nursing home, and the family have come in with a peace plan saying that they're not going to have any treatment with anything, then I would have a conversation with the family about, well, why are they still on a DOAC? If they've got a frailty score of 7 and they were still walking around in their nursing home, even if they've got dementia and they don't really understand what's going on very much, if they can still hold a pleasant conversation and they're enjoying life, I often say, well, if the family feel they want to stay on a DOAC and they don't want to have a stroke and be aphasic or paralysed, then it doesn't seem that unreasonable, if they're not having any complications from their DOAC, to leave them on it. Because to be paralysed from a stroke or totally aphasic you may not die from it, but it's not necessarily a very pleasant way to spend your last year of your life. So it all depends a bit on what the patient and the family want. Some patients just do not like taking tablets. If they don't want to take a tablet, even if they're very, very high risk of a stroke, that's absolutely fine. It's completely up to patient choice. If you give them the information, it's up to them to make the choice about what they do or don't want to take, or up to the family. So unless you really believe the patient's life expectancy is very, very limited, or they're getting major complications from the medication, post-operatively, if they came in on it, we probably would restart it again, but we often wait a good week or two to make sure that their wound is really, really healed, because you don't want the wounds bleeding post-operatively. So there are these anaesthetic guidelines have existed for quite a long time. We quite like it if we get specific anaesthetists for our lists, because like I said, the patients are very, very sick, and I think the anaesthetists find the patients quite difficult sometimes when you come and you see these patients with multiple comorbidities and they look quite moribund pre-op. So I think that's why this anaesthetist, Griffiths, developed these anaesthetic guidelines for hip fractures many, many years ago to guide anaesthetists as to what things you need to worry about and what things for your hip fracture patients you don't really need to worry quite so much about, because it's clearly not that uncommon for patients to have a slightly low sodium or a slightly low potassium or a slightly high heart rate, because with your neck of femur patient, they're quite a sick group of patients, and we know if you wait to sort out all these problems for the patient, you're likely to wait 48 hours and their mortality is going up. So I think the anaesthetist who developed this guideline was just trying to say, you're probably better to just get on and anaesthetise the patient, because they're probably just going to get sicker while you wait, rather than you'll be able to actually correct all these abnormalities. So yeah, there are clearly a few correctable ones here when their sodium's very low or their haemoglobin's very low. We try and get their haemoglobin higher than that. or they've got, you know, uncontrolled sepsis, uncontrolled diabetes, decompensated heart failure, or you really believe they're going to die, which can be quite difficult to predict. But an undiagnosed murmur, they used to cancel everybody awaiting an echo years ago. They used to cancel everybody who was on clopidogrel many years ago. And so you should wait a week for the clopidogrel to be out of the system. I mean, you know, and there's just be a lot of lack of sphere to space, but those things now have become totally unacceptable. You just have to get on and do the patients. You know, everyone has a heart murmur. So then common post-operative complications, all of these things, they are common and they're not always preventable, but I think you can minimise the chances of them happening, and I'm hoping from what I've already told you that you might take some of that away to your own specialties or to your future jobs and manage to do that. Delirium, it's very common and it's not always avoidable. You'll see that in any ward. It's not just related to the surgery, it's not just related to the anaesthetic, it's related to when you bring an elderly person, even if they've got an AMT of 10 out of 10, as soon as you bring them out of their normal environment and you put them under some stress, when they're sick, they can get an acute confusional state. It's said to be between 10 and 40%. I think our unit, we get about 20% of our patients get very delirious. The quicker that you can improve their delirious state, the better, because it is associated with quite a high mortality, especially if it's prolonged. So the things like the opiates, if you prolong their opiates and make them more delirious with opiates, so if you get their pain management wrong and you think that they're agitated because it's pain and give them more opiates, when actually that isn't why it is. If it's the opiates making them delirious, then clearly that's making their whole situation worse. I often liken it to if you're feeling a bit drunk, give somebody who's feeling drunk, if you give them more alcohol, that's making their whole sort of swimminess worse. Whereas if you rehydrate them with fluid, they're going to feel a bit better. We do the 4AT day 1 to 3. I don't know if you've seen the 4AT, we've got a target assisted discharge team that do that for us, a sort of physio team do that for us on the patients. And you basically need to think, well, what could be the cause of the delirium? Some patients do just become delirious. However, it's worth looking at the drug chart, looking at the electrolytes. Have they got an infection? We do get a number of patients who, because they're falling, may get a subdural. And we then put all our patients on Clexane. So that always sort of goes through your mind. Not every patient gets a CT head. I mean, when patients are very delirious, I try not to send them for too many investigations off the ward, because I think if you're in a really delirious state, to be wheeled up the corridor to X-ray and put in some sort of tunnel, probably feeling either too hot or too cold, with a whole load of people you don't know, must be very, very frightening for a patient. And unless they've got significant weakness, if they've got a subdural, is it actually going to change your management that much? It's true you may leave off the Clexane, but when they're really, really delirious, you're probably best to make things simple as you can on the ward, and then if it carries on, to CT their head rather than to rush a very, very confused patient straight to the CT scanner. Just concentrate on the basics on the ward first, and checking their electrolytes and doing the simple things, because I think that must be quite distressing for the patients. Urinary retention is quite an easy thing to resolve, which can make patients very, very delirious and uncomfortable. So assess their pain and have they got opiate toxicity, remove the patch. Once we've removed the patch, if we're not sure whether they're in pain or not, it's not uncommon that I'll say, remove the patch, remove the PRN oromorph, and just give the patients intravenous paracetamol. And you'll find over 48 hours, these patients are transformed. We work very, very closely with our physio team. So you say to the physios, if the patient's in pain, will you come and tell me? And the physios are really, really good at feeding back to us as to whether they think the patients are in pain. And just get the patient in a quiet environment. And if you can get a family member to sit with them, that's really good, which clearly we're not able to do at the minute. And the other thing that we find we have to have a lot of is falls alarms, because our patients, they do get up a lot and then they do fall a lot. And I can't remember the last time that I would have prescribed haloperidol or lorazepam for a patient, because I think if you sedate a delirious patient, it must be very, very frightening for them when they're in that state then to have a bit more sedation. So the only time I think we would do that is you occasionally get a patient standing up on the bed or trying to jump off the bed, or maybe being very, very aggressive to another patient. So it's only if they're going to cause significant harm to themselves or to someone else. If they're just a bit agitated, you're probably best to go with it. I remember once there was a patient sat on the stairwell in another hospital that I worked out at, and they called the security guards to remove this 95-year-old from the stairwell. And he just needed a cup of tea, and once he'd had it, he was just, because they didn't like him blocking the stairs, I think they felt he was a fire risk or something. So they get these two huge security guards in all their fluorescents to come and sort of try and move this 95-year-old who was clearly quite agitated, so quite strong at the time. I think he just had a cup of tea and a biscuit, and after half an hour he gently walked back to the ward. I just thought, these people must have absolutely petrified this poor old man, and it just, you have to get the right approach with these people and try and put yourself in their shoes, and then think maybe what might be the right approach to try and calm them down rather than make the situation a bit worse for them, because it must be very, very frightening. And even patients in the morning, if you ask them, who are very lucid, have you been delirious overnight? Have you had hallucinations? Many of them say, oh, well, the curtains did move last night. There were things running about on the curtains. And some of them, their AMT will be 10 out of 10. And when you've spoken to them for more than 5 or 10 minutes, they genuinely believe that the staff are the secret police. And if they have that paranoia, that is opiate toxicity. When they're totally with it, with their mental test score, but they're paranoid that the staff are getting at them, or something with the secret police is going on, or somebody's putting something in their tea, that's going to be the opiates making them confused or making them that paranoia, and that takes several days to get out of their system. So that's not usually electrolytes or infection, that's usually opiates. And then for sepsis, I expect you've all seen the sepsis screening tool. We tend to just use that on our ward again. And whenever somebody has a news of 5, that's what we like to think about. The only thing I'd say about it is it tends to tell you, the 3 inputs with the, the oxygen, the antibiotics and the fluids, and the 3 outputs. But I do think you need to think, well, what is the cause? And examine the patient and come up also with a differential diagnosis, and think about other secondary investigations. And occasionally the cause isn't very obvious. On our wards, you always have to think about pressure sores and obviously the wound. The wounds can get infected. People often think, has the patient got a urine infection? Urine infections in the elderly, lots and lots of patients have a totally asymptomatic positive urine culture. I don't believe that's often, if they're truly septic, it may be that they have got a urinary tract infection. If the patient is completely well and not septic, just because they have a positive urine dipstick, I wouldn't treat anything, and even if they get a positive culture, I wouldn't treat them for a urine infection if they're totally asymptomatic. And the other thing, when they're really they're septic and you're worried about them, is to communicate that to the family, that you're concerned about the patients, because it may be that they'll get worse rather than better, and it's better to inform the family sooner rather than later, because like I've shown you with the frailty score and the mortality, you know, our patients, they don't always do very well. With atrial fibrillation, it's to think, well, what's precipitated it? Is it a primary arrhythmia, or is it secondary to something? Is it secondary to sepsis, or is the patient very anemic? Are they very dehydrated? Could they have had a PE? Check their electrolytes, make sure that their potassium and their magnesium are sufficiently replaced, and just think about their stroke risk. It may be that they've been in atrial fibrillation before, because they're very, very likely to have an enlarged left atrium, and it may be that it's paroxysmal AF, and that just when they came in they were in sinus rhythm. And then with hospital-acquired pneumonia, I know even when they come in with a community-acquired pneumonia, people encouraged to do the curb score. I have to say, I don't tend to follow the guideline with our patients. As soon as they're hospitalised and they're bed-bound, I would treat them all with intravenous antibiotics, not oral, because they're bed-bound and they're given opiates and they're undergoing an anaesthetic, so they're very likely to develop a worse pneumonia than they would. Then they're not like a standard community-acquired pneumonia, and the curb score was used to see who you could treat as an inpatient and who you could treat as an outpatient. These are all inpatients. They're not mobile, and when you're bed-bound, you don't breathe normally. So we tend to treat them all with intravenous antibiotics. VTE is obviously fairly common also. The symptoms can be quite difficult in the elderly. They don't usually complain of chest pain. I wouldn't like to say who the last patient that had hemoptysis, and they don't even complain of shortness of breath. Sometimes we just get an isolated tachycardia and it can go on, and then you think, well, we'd better just CTPA them, and it's not uncommon then to find a PE if they're just sitting there tachycardic. And to do the Wells score for them. I'd never do a D-dimer because it's always going to be positive. D-dimer is only helpful almost in the community or in a patient that comes to A&E that you're going to discharge that's very, very well, because it's only a value if it's negative. To exclude a DVT or a PE, it's of no value in these patients, because you often get a false positive in trauma, malignancy, inflammation. It just shows you that your patient's sick. Well, any patient on the ward is going to be sick. All our patients have had an operation. The D-dimer is going to be high. It can be a bit similar with the troponin. They've all got a bit of renal failure, so the troponins are often high. They've all had a bit of muscle damage. However, if the troponin is negative in a patient with chest pain, don't just think, oh, that patient's not got a cardiac problem. Think, well, could they have chest pain because they've got a PE or for some other reason? You know, that can sort of catch you out if you're that's where having a differential diagnosis for things is very, very helpful. If you just always go in thinking of one diagnosis, and then walk away thinking I've excluded that diagnosis, you then have to think, well, what was the cause of this problem? Because it's helpful to have a differential from the start. Are you aware of the single unit transfusion guidelines? No. NICE have had a single unit transfusion guideline since 2015. We're busy educating the orthopaedic consultants about this, because it's not uncommon on the orthopaedic ward for people. I think we're getting there. So give the patient 2 units. The reason why they've said this is not for patients who are acutely bleeding, this is for patients who come, like post-operative patients who have a low hemoglobin, who are not acutely bleeding, because there's been incidents of transfusion-associated circulatory overload. I could see this happening. So in 2014 there were 6 deaths in the country from this. I could see this happening, in elderly patients, because if you look at the weight of some of our patients, it's not that uncommon for them to be under 50 kilograms. I'd say, on our ward at the minute, there's probably 3 or 4 who weigh 42 kilograms. So the amount of blood volume that they've got is significantly less. So if you go and give them a 2-unit transfusion, it's significantly more blood than if you're giving it to a 70 kilogram person. So although pre-operatively, we do encourage our juniors to keep the blood count at more than 100. Post-operatively, in frail elderly people, we aim at 80. And what? No. Something there. Oh, I've gone too far now. Do you think I can go back? Go on the right one. Oh no. How do I go back? Go back. Oh yeah. There's one more on one. One more. No, on one. Forward now. Oh, that's it. Yeah. Okay. So yeah, I mean, they recommend in, I think, younger people that your haemoglobin level should be 70 before you transfuse someone. I have to say, in our frail elderly patients, we go for 80. And sometimes we might look at them clinically. If they've started out with a haemoglobin of 140 and they've ended up with a haemoglobin of 80, and every time they get up they faint, clearly we give them a unit of blood, because some patients, they just can't manage with losing 6 units of blood, and that's absolutely fine. Or if you've started out with a haemoglobin of 80 and it's still 80, and you've got chronic renal failure, then we don't need to give you any more blood. Or if it's ended up at 75 and it's now 80, but your baseline haemoglobin was 80, then we wouldn't give you any more blood. So it's a bit dependent on the patient themselves. But we try and encourage on the ward to only give 1 unit, then recheck the haemoglobin before we ever give a 2nd unit. It's obviously, even at pre-op we try and do that, but pre-op we obviously try and get the haemoglobin up to 100 because we know they're going to lose blood, but post-operatively we'd be happy if they're at 80, if they're not majorly symptomatic at 80, because generally the haemoglobin will slowly creep up in the patients. Then there's a little bit about orthopaedic complications. Most of our patients, I would say, do not experience post-operatively. Pre-operatively, I think it's quite uncomfortable having a hip fracture, especially when you're moved. Post-operatively, I don't think they experience what I would call excessive pain. It's amazing how day 1 post-operatively, they got out of bed, they'll sit in the chair, some of them would even walk a few metres with the physio. I don't know if when they're elderly, their pain fibres don't work so well, or if they're just quite stoical, or if our pain management strategy that we've got is effective. But so if you've got somebody who is in excessive pain, then you probably need to think that's slightly unusual. I wouldn't like to say when we've upped a buprenorphine patch to 10 from 5. It's very, very rare for that to happen. So it's very important to re-examine the patient, or re-x-ray the patient, or ask our surgical colleagues to have a look at the patient, because sometimes the hemiarthroplasty dislocates, and that I think is very, very painful. That has happened in patients with dementia. We're not sure at what point it's happened, and of course the patient's been in a lot of pain, and when you've got dementia and you're writhing about in pain, people sometimes think, oh, it's just because you're confused and you've got dementia. And when you're a physician, sometimes you forget a bit about the legs because you're thinking about the dementia and the delirium, and then you get a bit bogged down in the dementia and the delirium, and then them having pneumonia and them having electrolyte imbalances, and then you forget to look at the leg. And then they're not getting up because they're delirious, so the physio's not looking at the leg, so it can be little bit tricky. I mean, the nursing staff are, but the patients can be very, very difficult to assess. So it's always worth just thinking, I wonder if it might be something more. And then occasionally, happens more a bit later on, dynamic hip screws that you do for hip fractures, they can, screws meant to be here, they can cut out, which again I think must be quite uncomfortable for the patient. So if you get a patient in rehab or in general practice who says, oh, it's really, really sore, it's probably worth re-x-raying it, just because things can go wrong with the metalwork. Even if the patient's not fallen, things can move about a bit. You can also get patients with, I expect from A&E, with hip fractures that don't show up on the first x-ray. And the recommendation then is if the x-ray of the hip, if the patient's fallen or still complaining of pain, even if they can walk, we get people who come in and they're able to walk for a few days and hobble about, then they should have a CT. And if their walking has significantly changed, especially if they've fallen, it's worth CTing them to check that they've not got a hip fracture. The other problem that we get is, if you worked in orthopaedics on our wards, is you're asked to see because the wound's oozing. Is it blood stained or is it serous? Generally, wounds, they should be dry, be getting drier, and by day 7 post-operatively, the wound should be dry. The nurses usually look at the wounds, but when they're oozing, it's important to get the orthopaedic team involved, because some patients develop a deep infection, which is this, slightly, we don't really see what I would call a superficial infection. Some patients get a hematoma under the wound, so it just starts bleeding a bit after the operation. I don't think we generally put patients on an antibiotic on the ward for just a bit of a superficial infection. It's not really what you see. But a deep infection, when it keeps oozing, you get a little bit suspicious because the wound should be dry. Some patients have a dry wound for years, and then years after, they suddenly get a deep infection in the metalwork. I don't know why that is, but it's a devastating complication for a patient to get a deep infection. And you need a senior review, and it's something that needs to be taken very seriously. If the wound's not settling, the wounds, they just should settle, and they should be dry. And the Clexane, unless it's really, really bleeding through into the bed, we tend to carry on with the DVT prophylaxis on these patients, as long as all their clotting and everything is normal and there's nothing else, like their platelets have gone low, and that's what's going on with it all. And then, we couldn't do any of our work without having the multidisciplinary team, obviously. We've got the physios, the occupational therapists, we've got our physio assistants, all the nursing staff and the dietitian, and they all get involved in all of this. We've got to get the palliative care team involved with our end of life, and we do very, very early discharge planning for the patients. We have the intermediate care team that picks the patients up when they get home. We do the falls and the osteoporosis assessments, but I wasn't going to talk about that really today too much. So the things that I find very helpful on the microguide that I just wanted to direct you towards was, I don't know whether, have you got the helpful pharmacy handbook on your microguides? Have you uploaded them? Yeah. And the bit, because sometimes I find the bits quite difficult to find on it, but was the anticoagulation with the thromboprophylaxis. I noticed on the junior handbook the fluid management bit was quite helpful, and now they've added on the doctor's handbook also the bit about management of hypernatremia. If you like reading, there's a very large document, more than 100 pages on the intranet, which the haematology department have put up, which tells you everything you want to know about anticoagulants. Stopping warfarin, starting warfarin, how to restart warfarin after elective surgery, what doses to give, what dose to give day 4 after the INR is 1.8, what to do when the INR is more than 10, everything you want to know about DOACs, every single different DOAC there is, what to counsel the patient, how to discharge a patient on a DOAC, how to discharge a patient on warfarin. There is so much information on there for anything you need to know, because they're quite dangerous drugs, really, and lots of patients are on them. And then we will be adding an orthogeriatric section to the microguide at some point, but that is work that's still in progress and somehow takes many months to do. So were there any questions? Anything else I can help you with? Or anyone else? No. What specialties do you work in? Oh, palliative. Oh, do you? So you know what to do with it? Them all. What do you work? Oh. So no one's surgical. Maybe you'll swap to surgery at some point. Oh, is there one on the chats? Oh, where's that? I tend not to use OxyContin because we'd like to keep things simple. I'm not sure that many people, or it's more complicated to understand all the different types of morphine derivatives. When you move then from Oromorph to Oxynorm or OxyContin, the dosing is very different. And I'm never quite sure whether everybody understands that when you've got Oromorph, we use 2.5 to 5. When you swap to Oxynorm, which is meant to be the one that's renally excreted better in the cleaner drug, if you use 2.5 to 5, that is equivalent to double the dose. So it's equivalent to 5 to 10. So although it's renally excreted in cleaner, if you're then giving a delirious patient double the dose, I sort of feel that's maybe a slightly not a helpful thing to be doing. And I find if you just keep it very simple and everyone understands what you're giving, we don't find that we use much Oxynorm. OxyContin, I think that I'm not quite sure what the lowest dose that you can possibly give of that, whether it's 5 or 10, but even if the modified release is 5, then that's equivalent to 10 of morphine. So if you're giving 5 BD, that's like giving 10 BD. So you're giving a patient 20 milligrams BD of morphine. With our buprenorphine patch, a 5 microgram patch is like giving 10 milligrams a day of morphine. And like I've said, in probably at least 20% of our patients, that's too much morphine, and I'm taking it off. I wouldn't want to give any more than that, so I wouldn't want to give OxyContin to patients. Does that answer the question? Anyone got any other questions? Maybe not. Yeah. Thank you all for listening. You'll be very welcome on our ward one day.
Grateful if you could fill out the award with your emergency form, please. Thank you very much.
Should I? Are you going to stop us?
Yeah, thank you. Lots of thanks. Thank you very much.
Oh.
recording is making me sure. Yeah, that's fine. Thank you
All
very
right, so
much.
stop recording.
Yes.
Thank
Lovely,
you.
thank
Nice to
you.
meet you.
Yes, nice to meet you too. Yes.
I hope we could call on you again next time.
I've done it once. Thank you. The IT stuff. Like maybe next year. Like me normal.
We practice it for you. Yes, we hope.
Yes.
We're hoping next week. As such.
It's because it's the young, but if they think it's going to go into the elderly. And I suppose they're worried because at the minute, everybody's still been outside because the weather's been good, hasn't it?
Yes, yes.
I suppose they're worried.
Yes.
Because if you think it's what it's like in December,
Yes.
and everybody's indoors,
Mhm.
and the weather's been so good,
So
and
good.
people aren't chesty.
Mhm.
And you think what it's like when people get chesty. You know, elderly
Which
and
might
indoors.
happen, yes, round about autumn, which
You
we're
know,
approaching.
it suddenly it's got colder, hasn't it? And as soon as it gets cold, and then if people are indoors, I don't know. And people don't mind queuing outside a shop and doing things, do they, at the minute?
No, no.
But people will not want to do all that, and then people's behaviour might change, and people have been eating outdoors at a restaurant,
Yeah.
and then they'll start having enough. And people get out and walk, don't they? Whereas if you stop doing all that, and then they've all got COVID, and then they're all
Meditate, yes, that's very true.
huddling up and vegetating. Because even young people, if you suddenly then feel a bit ill,
Mm.
and then you take to your bed or
Mm.
sit about, you'll get it a little bit worse, I reckon.
That's very true.
Whereas when when it's something you think, oh, I've got a slight cough, but it doesn't matter, I'll just go down.
Yeah.
It doesn't sit with you, does it? You shake it all off. I mean, maybe you spread it, I don't know, I've no idea. Time will tell, I don't think any of them know.
No, this is it, even the most intelligent, or very, very,
It's all just modelling, isn't it?
Yes.
They don't really know.
virologists, brain
They don't know.
No, they don't know where it's going.
And they must be worried about if they get a flu
Yeah,
and COVID.
yes.
Because they're not going to know, are they, if you've got a cough, if it's a flu or COVID.
It could be SARS.
Oh, don't.
Yeah. This is it. SARS is not, it's still there. It hasn't
they're
really
not gonna know.
disappeared, yeah. Just because.
But it's a bit difficult, isn't it? And all the students back in school, but they've got to get on with some normal life. It's not nice for young people, is it?
No, but all the same.
And
don't-
maybe older people, if you think you're a risk and you stay in,
Yeah.
and that's how life's going to be. But it's been so bad for older people.
Mm.
The lockdowns, the number of people that said, oh, I lost my balance, I can't walk anymore, I've not been going out, I've not been getting in my car, I've not been going to the shops, and they've got deconditioned 6 months. But then I think really old people, and you think, if your life expectancy is 2 years, 3 years, and you don't cuddle with your family, see your family for a year,
Yeah, that's terrible. That
you're
is
never going to
terrible.
live 3 years.
Yeah.
When you spend a year away,
Yes,
not seeing your family when you want to,
that's
in
cruel.
your house,
Yes.
it's not right, is it?
No, it's terrible.
It's not humane.
No, let's just get on with it. If they want to be that way, let them.
Yeah, let
Be
people
that
make
way,
a
yeah.
decision. But then I suppose it's you know, if your husband's 50 with a kidney transplant, you might feel very different.
Very true.
You know, or your son was, you know, with a kidney transplant at 20, and then when you hear everyone's got it, you'd feel a bit differently.
I would, but on the same
You know,
time,
You know, if they died of it,
take his
you know,
life,
then you might feel a bit,
Yeah.
well, what is everyone being irresponsible?
Do we-
And also we're fortunate living here.
Yes.
Because that's the other thing.
It's very,
Yeah,
very
maybe
good.
if we lived in Birmingham or Manchester, and we felt everyone was getting it, we'd feel very differently. But because we live here, I think we don't feel the same.
Yes, that's
So I think that's the other thing, we might be in our own bubble. We're not. And we're lucky, we've got a lot of outdoors, a lot of space.
Yes,
Quite
and
sensible
we're
people.
very close to sea.
Sensible people. You know, so we haven't been lucky, but I don't know.
No, because we've just come from a whole holiday and then we found out, gosh, the infection rates going up. But on the same token, we say, well, that's good that people being tested. And you know where the infection rate is going on.
Because before, no one was getting tested, so they didn't really know how they did it.
And
So
now-
back in March, it might have been going up 20 times. They didn't know, did they?
No, because
They didn't
don't
test
have-
anyone.
Exactly. And the only ones that were tested were
In hospital.
clinicians, yeah. So that doesn't count for me because they work or, they have to be protected. All clinicians have to be. But on the same token, what about the people, that were being treated? How many have they infected? Yeah.
Although that when they've done the antigen test, not that many were infected,
No,
which was a bit odd.
my family, both my son and my husband, had a really bad cold and went on for weeks on end, and then we
And they
thought,
didn't have it.
no,
No, my son had a bad cold in February, and he was in Brighton. I thought he would have had it. But
yeah,
it was clearly the flu that was bad, wasn't it, with the cold?
he was.
It was bad this year, and everyone thought they'd had it, and nobody had it.
It was just the flu. It was terrible. It was terrible.
Really bad cold.
Yes.
And everyone thought they had COVID, and they didn't.
Exactly. And yes, my son said,
My son was still for 2 weeks.
mine was
Coughing.
He was flying for John Seacam, as a paramedic. And he was very, very ill, and I said, oh gosh, what's going to happen? Because he was waiting for the result of his interview. He was interviewed in January, and then a week after the interview, he got really ill, and just went on 5 weeks. What did they I get offered a job, and then there's this thing. And of course, he got offered a job a week after he's just recovered. Oh, good. That's good. So, thank God for that. But if it was a week before, oh my gosh, I don't know if they would take him in that state.
So he's got a job.
He's going to
That's nice.
That's good. But yes,
How old is he?
he's 26. Yeah. So, yes.
Nice to have got a job.
Together with, yes, with the story. But recently, he read the ambulance service with Zika. That's what you call this? Yeah, 30 cases in the last 6 months. Yeah.
At work or not?
No, at work, yeah. Yes, they're literally, being attacked by whoever calls them, and then suddenly, yes. Yeah.
Not just sort of random.
No.
It's intentional.
Yes, it was intentional, mainly the drugs.
Oh.
Yeah.
Do they just let them have it?
Well, what happened? One of my son's classmates, who got a job here, my son got a job in Ashford, but she got a job here in one of the ambulance services in Hastings. What happened is they called her, and she was with another colleague, already experienced paramedic. She's a newly graduate one. They were, when they arrived on the scene, they couldn't find the dress, and then suddenly they were passed on. Yeah. It took whatever they could to protect, but of course, all the ones with heavy drugs were have to be coded, and then they were asking, where's the key, give us the code. They wouldn't say, yeah.
So you beat them up.
One was, hit.
But
Yes.
it's better. There's
Yeah.
nothing else.
And as I said, that's why they were saying, you know, they would have body
Yeah.
cameras, there's like police. Yeah, because the incidence of crime, you know, against staff is ever increasing. And it's rather demoralizing. You're just a newly graduate, and then you get that kind of
But
experience.
it's probably not the majority of the work.
No, yeah.
That's how you've got to think.
Yes, yes, I know that not everyone, not all people that call the ambulance service are like that, but yes, it's
That's
very
what I'm
demoralizing.
working now.
Yes, likewise.
Whereas when you're working on, these older people, they're really sweet.
Yes, and the thing is, they're elderly, so they rely on you, and that's kind of the life they rely on you, whereas the ones that come in.
They're very
or the ones-
genuine. They're very genuine.
Yeah. And you know them.
They always need to.
Yeah.
There's nothing, you know. They're very genuine. Breaking my head with them.
No, absolutely.
We'll be like that one day.
One day, indeed, yeah, I'm practicing how to do several things.
They just need treating gently.
Yes, all things, yes, exactly. I remember my mother-in-law, because she had a stroke. Yeah, and unfortunately, it affected her brain. So her memory, she doesn't even know how to make a cup of tea, which is really sad. And she was a fantastic cook.
It's sad, isn't
Yeah. And she calls me with a name that the last name she used. So if that happens to be a man's name.
it? Oh,
Yeah.
because of the stroke, yeah.
So yes, her long-term memory is totally gone. Yeah. And it's just whatever she's remembered. Yeah. Thank you so much for this.
That's quite nice.
It's lovely.
I hope they learned something. I'm
Oh,
never
yeah.
quite sure.
Yes, they have, yes.
Basically.
The thing is this, the lectures are in the afternoon more or less, as you know, serotonin level goes down.
Yeah, that's right, yeah.
So
Sit
yes,
there.
yeah, and you know, and I just said to my
Education.
manager, why can't we have the lectures in the morning? Well, the thing is, they do more crowds in the morning, yeah, and a lot of handovers are in the
Yeah, it's
morning.
busy.
It's very busy at the moment.
But anyway.
There you go. Yes.
So I get something sent through to you about what they think.
Yes, I will, and I'll give you also a medical certificate of teaching, yeah, saying,
Nice to meet you.
nice to meet you, Charlotte.
So they can't be bigger.
What are all the grapes? Well, some are. Some are, majority are very good. Yes, really good. Okay, I'll scan them and I'll send them to you. Okay, thank you. I'm sorry. Take that from your pile there. Thank you. Fun to harvest. Yes. I have to stay there because the consultant has just used MS Teams. She doesn't know how to use it. So doesn't know how to go back on slides. All she knows is to go forward. So I have to sit there, yeah, and show her, but that's okay. It's fine. She said, yeah, she'd like to do it again, so we practice. Stop.